if we transition, you made the comment of, okay, if there's 1 in 20 infiltrates that wind up being MK and 10 to 15% of those wind up with vision loss, then you've got to look at the idea of this, which is the second part of my question that I wanted to have you kind of delve in a little bit more on is, all right, well, what is the actual like numbers needed to treat? If we can reduce your risk of myopic maculopathy from a -6 down to a -5 by 40% by preserving that one diopter, how many of those -6 patients, or who would have been a -6 patient had we not intervened, would we need to intervene on to save that one diopter? Are your numbers get into that?
So there is. So you've seen a couple of sort of glimpses, pieces of data. So you've seen the safety data, but and you've seen a little bit of the data on risk of myopic maculopathy as a function of level.
Is there more that's not published?
Yeah, well, there's stuff that's under review. So let me sort of join the pieces together. So first of all, you're very sophisticated in so much you mentioned number needed to treat. So the number of kids that you would need to treat to slow myopia by an amount to sort of produce that benefit is actually very low. Mm-hmm. It's in the single digits.
It is.
Yeah. Let me pull up.
That's pretty powerful then.
So
and your number needed to harm is actually quite high based on the data you've just shared.
So
see, this is compelling stuff because this is the kind of stuff that makes people really say, like, when people say now a standard of care, I think, it's part of my care. I don't know that it's standard of care, but if you get into the point of saying number needed to treat of less than 10, that's pretty significant.
So there are. I'm going to sort of throw some general numbers at you. Sorry.
No, that's why I wanted you on. Hello and welcome to the Gristmill Podcast on iCode Media. Today's conversation is part 2 with Mark Bullimore, and we're discussing specifically the incidence of infections in children who wear contact lenses, some of his literature related to that, and also the literature related to the amount of vision that we can preserve by reducing overall myopia, which is super compelling. And actually, he gets into data that hasn't been published yet. So the data that I've seen sort of scratches that surface, and he was able to answer ideas of things like number needed to treat and number needed to harm, and really bring those two ideas together based on his evaluation of all of the evidence that is available to us. So it was a really great conversation for me because it helped me wrap my mind around the full impact of what we're doing with myopia management. And so I'm really grateful for Mark to be on and discuss that. And so please enjoy our conversation. As always, be sure to subscribe to the podcast, write a review, and share it with your friends. And support those who support us. We've been providing myopia control treatments in our practice for years. If you've been listening to the podcast for a while, CooperVision has received FDA approval of its innovative MySight one-day contact lens. This will be the cornerstone of a comprehensive myopia management approach to be offered by CooperVision. This daily wear, single-use contact lens is the first and only FDA-approved product clinically proven to slow the progression of myopia when initially prescribed for children 8 to 12 years old and when compared to children in the control group wearing a single vision one-day contact lens. Check out the show notes for all the specific prescribing details and to get more information about this lens and how you can begin to offer it in your practice.
This has been fireside chat sort of territory here.
Yeah. So I think there's kind of two questions that I want to pick your brain about. And one is not to be, is because I think if I can understand the data better and where the actual data is coming and how you find those, like one would be the 40% of saving one diopter of myopia. How do we get there? And two, the infection stuff. So if I can, and I've read both of those papers that you've put out, but maybe and I'm not opposing you in this. I just think the better I can understand it, the more convincing I can be to other people, because I know there's a lot of people that are just like, they still think contact lenses in kids, not going to do it. They still think myopia management, not really that helpful long-term or short-term. It's more effort than it's worth it. So in my effort to try to make sure that I'm communicating as effectively as possible to people and trying to also tell them about the evidence, but then kind of, I think the evidence guides us into why it's important. The better job I can do explaining the evidence, the better job I think, or the more people will say, yeah, this is important. So those are kind of the questions, like how did you get to that point to be able to say, yes, this is how the evidence shows us that contact lenses in kids are safe. Can you tell me about that?
Yeah. So those are two great examples of sort of, me sitting at my computer and trying to pull things together. Now, the other thing I talk about, being a industry-funded academic, both of those pursuits were really stimulated by interactions with industry or people coming to me and saying, hey, could you put something together? So let's talk about the safety aspect. And, before I give you the long history, let me give you the sort of disclaimer. People might regard me as a hired gun and, a keyboard, have keyboard will travel. But my brand, my reputation as an academic is the thing that's most important to me. So if somebody says, can you say this? And I'm going to say, well, if the evidence supports it, yeah. So, pulling information together is important, but I have the freedom to come up with whatever answer I'm led to. So in the case of safety of contact lenses in children, so I'd done some work on contact lens infections and epidemiology. I'd been involved in Focus Night and Day's pivotal study, which involved almost 10,000 patients, and looking at the rates of infections and classifying what was serious, what wasn't, amongst those. So I had a little bit of involvement there, and then again, just before I had left, about the time you were graduating from optometry school in about 2008, I had done a study that was commissioned by Bausch and Lomb and Paragon to look at the safety of overnight orthokeratology. And in that particular instance, essentially, overnight orthokeratology or CRT had been approved without age restrictions, basically, for the temporary reduction of myopia. But then, unexpectedly, in the eyes of the FDA, it started to be used a lot in children because we were learning that it could slow myopia progression. And at the same time, there was a whole slew of case reports out of the Far East, mainly showing that we were getting some serious infections in children. So the FDA said, hang on a minute, they have a mechanism. We need you to do a post-market study to provide some data on safety in children. So we had done that study. And again, it was a company-sponsored study, and it sort of gets criticized in some quarters for being unreliable in that regard. But we're dealing with the FDA, okay? They have badges and guns, okay? The government, all right? And it's my academic reputation on the line. We did the study. The data are what they are. Do it. So anyway, about 5 years ago, Gary Osborne from Cooper Vision said, hey, Mark, would you be able to write a white paper on the safety of contact lenses in children. And this was ostensibly to support the product development of my site, and as part of either submission to the FDA, but in terms of educating practitioners, we're going to get asked about this. What do the data say? Okay, what do the papers say? So again, off I go. How many papers can I find that have followed a meaningful number of children for a meaningful amount of time to contribute to some estimate of the safety of contact lenses in children? So I was able to identify a number of prospective studies, most of them related to myopia, or there was a big paper out of Ohio State, Jeff Wallin, on self-esteem and contact lens wear. So, you put all the data together and you sort of like, looks pretty good. And at the same time, or just previously, the Clay study group, who are a group of largely women optometry academics, had done a similar study. You see my research assistants just arrived. A similar retrospective study looking at the rates of infections or the rates of adverse events in different age groups. And they basically came to the same conclusion I did on the prospective studies, that actually children are the safest. Teenagers are have a higher rate of infections, and then college age people, I don't call them adults, college age students have an even higher rate of infections. So the kids are the safest, in part probably because there's adult supervision, and the kids listen to their parents at that age. Teenagers, less so. College age, zero adult supervision.
Yeah.
So,
and they also have a history. That's the other question I would wonder is, they also now have a history of things being okay, right? If they started wearing contacts when they're 8 and they were fine, and then now they're 16, I've had 8 years of history, everything's fine.
Familiarity breeds contempt.
Yeah. Did you find that? Do you find that in the evidence? Beyond what you're just describing?
Yeah, you see that, I think, all the time, and you probably see it in your practice.
Yeah.
There is a biological aspect to infections that we still don't fully understand, but we do know that if somebody gets a corneal infiltrative event, and I'll use that as a catch-all, that may or may not be infectious, they're 4 times as likely to get a subsequent one than somebody who hasn't had one before. So there's an innate sort of risk. I was one of my master's students, this is going back 20 years, at OSU. We did a study. We were looking at corneal swelling with these new silicone hydrogels with overnight wear. I wore the the Bausch & Lomb lens, the Pure Vision lens.
Yep.
First night I slept in Pure Vision, I woke up with a red eye, infiltrate. Okay, ran over to the contact lens clinic, contact lens lab. Let every second year student take a look at it. This is what this is what it looks like. Okay. So again, that's part of the joys of being in a teaching institution or an academic institution. You basically you can take somebody out of the research lab, like myself in this case, and sort of say, look.
Here you go. Yeah. Do you think? Well, so let me back up on that again, because when I was being trained, it's not something I think about nearly as much anymore, but there is this proportion of the population, in my experience, that tends to have reactions like that to a silicone hydrogel lens. It's not a ton, maybe 5 to 10% in my experience, but
shit happens.
Yeah. So, but that seems to be less of I guess from a contact lens company standpoint, it seems to be that most contact lens companies aren't concerned about that. Because they seem to be moving everything. There's some companies that almost exclusively just have silicone hydrogel offerings, at least in a monthly standpoint. So, what are your thoughts on that?
Again, the silicone hydrogel story is an interesting one. in so much that we thought it was going to be a panacea, first of all, for overnight wear and then for daily wear. But, the evidence is quite clear that even with daily wear silicone hydrogel lenses, you get a higher incidence of these little ditzels than you do with conventional hydrogel, okay? It's the nature of the material. Now, there are other advantages to the material, but, that alone stops it from being a clear, stops everybody from moving to silicone hydrogel.
Right.
But so it's there's some good things and bad things. Now, as I said, with those little peripheral ditzels, the corneal infiltrative events that we see more commonly with silicone hydrogels, they're generally innocuous. Okay, right. You take the person out of the lens for a few days. Because you're a naturally conservative guy, you treat it with a topical antibiotic. Even put a steroid on top if you want them to feel more comfortable. You do what you do. You be the doctor, and then you move on. But it happens, and I was certainly one. I was a poster child for that, based on one night of overnight wear. But the other thing that has really sort of, I would say, revolutionized safety and really makes it very attractive in anybody but children in particular, is going to daily disposables.
Yeah.
So, one of the key things that's attractive about my site is that it is a daily disposable lens. And, we know that sleeping in the lens is probably the number one risk factor for increasing rates of infections, but things related to solutions and cases are sort of 2 and 3. So if you can get those 3 things out of the way, you're likely to have better safety of a contact lens. I would say the other thing that's been equally important is these.
Yeah.
You can now, in any of your patients, they can call a number if they've got a problem. So, I would say if I was seeing patients, if you have a painful red eye, you need to reach out to me right away so we can address it. And as your doctor, I'm available to you.
Yeah.
I think if you say painful red eye, you're going to see some uncomfortable red eyes as well. But again, you can nip it in the bud. You're an associate, can see it and deal with it right away before there's a risk of it being more serious. But
and that's in the literature that you looked at and reviewed. What were those numbers like when you said, because I think that's a great point too. I mean, I think those are the 4 big ones that I think about is, obviously sleeping in lenses, cases, solution responses or solution improperness, and then also how quick somebody gets in to see those.
Yeah.
So if you mitigate that, what's the numbers for kids in contacts?
So basically, in all of the studies I reviewed, there was not any cases of microbial keratitis in 8 to 12-year-olds. Now, and that represents probably over 2,000 years of wear. Now, in the recently published Blink study, which 3-year study, Ohio State and Houston, randomizing kids to 2 different strengths of bifocals or a single vision lens. They did have one case of presumed microbial keratitis, but if you look at the details of that case, and they presented it at the academy meeting as part of the general safety profile, it was pretty iffy. Okay.
You say iffy as in they were just being overly cautious, or iffy as it might have been a peripheral infiltrate that had a little overlying staining and they just called it microbial keratitis?
That was you nailed it. Okay. It was a relatively small peripheral, so one of the things, hindsight's 2020 or 2015. one of the things that Wallin acknowledged, he said, they didn't go into this study expecting to see these things, so they didn't have a classification scheme in place. So, so basically, they had the Data Safety and Monitoring Committee reviewing these adverse events, and there were 3 optometrists or 3 clinicians on that group who sort of made a decision on this. But it was a peripheral infiltrate. I think based on its size, it wouldn't have met the criteria for probable MK in some of the studies that I've been involved with. So, the ortho case study that we, that we did, even before we started reviewing cases, we had our criteria for what was probable MK, what was possible MK, and what was not. So
do you have that off the top of your head? Like, because I'm not a researcher, but I think it's really common.
It would be the same things that you would look at. So basically, to be probable MK, you need to have an infiltrate that's at least 1 millimeter in diameter, overlying staining, pain greater than mild. So, it can't be just discomfort. It has to be pain. And then one of the 3, a purulent discharge, an AC reaction, or what's the third one? Or a positive culture, I think. So If you look at different studies, they typically use that construct.
Right.
And then they will just below that have a sort of possible MK that fails to meet all of those criteria. So it might not be big enough. There wasn't that much pain. There wasn't really any sort of nasty discharge, AC reaction or whatever, but you thought it was still probably, or might be an MK. So typically, so if you take all infiltrates, all infiltrative events in soft lenses, 1 in 10 or 1 in 20 typically be classified as MK. Now, again, you have the ability to treat and be cautious. You treat them all the same.
Right.
Okay.
Right.
And that was something that we went back and forth with the FDA on in that ortho case study, because they said, treatment, if the treatment was consistent with MK, then that would make you think. It's like bollocks, okay? Yep. Because Chris Wolfe is going to reach for the same antibiotic, whether he thinks it's MK or he thinks it's not MK. All right. I mean, so we have the ability to treat, we treat. Okay. So the treatment's it isn't a good indication of what the practitioner thinks, but generally, as you've probably already figured out, when you're doing these studies, either prospectively or retrospectively, you don't let the clinician decide. You don't let the clinician's treatment dictate. You have an independent panel of 3 to 5 people who look at the case and say, what is it? Okay. And it's like what do you call it? Mortality, morbidity conference in a hospital, which they have on a regular basis. Okay. Who died? All right. But what are we saying here? Because you want transparency, but you want to get ahead of anything that might be coming down the pipe. So those are the things that you look for. And the challenge in the Blink study is they didn't have a construct there. Could they have gone to a Shine paper or a Bullimore paper or a Chalmers paper and said, let's use what they did? Yeah. But they had one case. Okay. Right. But it was pretty, it was, and it was the same actually in the MySight retrospective study. They had, it wasn't MySight lenses, but the FDA wanted a large retrospective practice-based sample of young soft lens wearers, and to get another estimate of what the incidence of microbial keratitis might be. And again, if you dig into those data, I think they had 2 cases of MK, but they were pretty soft. And the other thing that you have to remember is that my watch.
No, it's all good. It's all good.
No, it's just telling me there's another podcast for me to listen to. But the other thing is, you've got this basket of infiltrates, and a small proportion of those will be classified as MK, and of those, a small proportion will lead to any vision loss. So typically, between 5 and 15% of MK leads to vision loss. So that's an important thing when we talk about placing safety in the context of vision saved by reducing the risk of maculopathy or whatever. Not just because you've got something that is an MK, it doesn't mean that that's vision loss. And again, some people lose that. Patient's got MK, and part of that comes from the ophthalmologists or optometrists who work in a hospital who see the real train wrecks.
Yeah.
And part of it is just misconception that people say MK, vision loss. No.
Right.
Even in the most conservative of cases or conservative of studies, it's 15%. But when you look at other studies, it's 4 or 5%. And again, what kind of lenses were these people wearing? What kind of care systems were they using? When was this? Yeah. So the field.
Did they get into? And is that study being done by a tertiary care center that is seeing the train wrecks, and not in primary care that is taking care of a majority of them before they get back?
Some of our best studies have been done in Australia, where optometrists weren't treating these things, and at the time that the studies were done, in the late 90s, anything that was, any corneal infection was going to be seen at one of these hospitals or one of these tertiary centers or whatever. So chances are that they were not only capturing the mild ones, but also the moderate and the extreme. And if anything, you probably did see more severe cases because of the setting. If you do the studies as part of, as prospectively, like the Blink study, and you end up with, 300 kids wearing soft lenses for 3 years. So that's as big a sample you would get outside of an FDA post-market surveillance study. That's a huge data. So you're going to see shit, but generally, you would not expect, even in that number of cases, to see perhaps more than one case of MK or possible MK, and you certainly wouldn't expect to see any vision loss, in part because it's extremely rare, and in part because these kids are in a study, and they are kids. They're getting there's more caution, there's more care involved than perhaps, somebody buying contact lens online as a young adult and, not paying too much attention to things. So,
so then let me transition that into, because I do want to be respectful of your time, is that if we transition, you made the comment of, okay, if there's 1 in 20 infiltrates that wind up being MK, and 10 to 15% of those wind up with vision loss, then you've got to look at the idea of this, which is the second part of my question that I wanted to have you kind of delve in a little bit more on, is, all right, well, what is the actual numbers needed to treat? If we can reduce your risk of myopic maculopathy from a -6 down to a -5 by 40%, by preserving that 1 diopter, how many of those -6 patients, or who would have been a -6 patient had we not intervened, would we need to intervene on to save that 1 diopter? Are your numbers get into that?
So there is. So you've seen a couple of sort of glimpses, pieces of data. So you've seen the safety data, but and you've seen a little bit of the data on risk of myopic maculopathy as a function of level.
Is there more that's not published?
Yeah, well, there's stuff that's under review. So let me sort of join the pieces together. So first of all, you're very sophisticated in so much you mentioned number needed to treat. So the number of kids that you would need to treat to slow myopia by an amount to sort of produce that benefit is actually very low. Mm-hmm. It's in the single digits. And
it is.
Yeah. So let me pull up.
That's pretty powerful then.
Yeah. So
and your number needed to harm is actually quite high based on the data you've just shared.
Yeah. So
see, this is compelling stuff because this is the kind of stuff that makes people really say, like, when people say now a standard of care, I think, yeah, it's part of my care. I don't know that it's standard of care, but if you get into the point of saying number needed to treat of less than 10, that's pretty significant.
Yeah. Yeah. So, I mean, there are, I'm going to sort of throw some general numbers at you. Sorry.
No, that's why I wanted you on.
I'm just pulling up the paper here so I can actually give you the numbers. So one of the things, and again, this was something that was requested or by CooperVision, young lady in the UK called Elizabeth Lum, who's an optometrist and is sort of in charge of medical affairs in Europe. She said, "Hey, would it be possible for you to compare the risk of vision loss associated with wearing contact lenses with the benefit of preventing vision loss associated with myopia control?" And she asked me this 2-3 years ago. And like so many things, I didn't have the answer right away. And I thought, it's my interest in it. Let me think about that. Let me think about it. I thought about it some more. And, the challenge was that you had to compare data on the incidence of a monocular infection and the incidence of vision loss in a young kid wearing contact lenses with the potential prevention of visual impairment somewhere down the road associated with a diopter of myopia control. And it took me a long while to figure out how to put those pieces together because they were, initially you're comparing apples and oranges. Okay, you've got data on risk based on incidence, and you've got data on risk of prevalence and vision loss. So let me go back to your the issue of that you asked about number needed to treat. So this paper was submitted for publication about 2 weeks ago. It took a long time and went through a number of iterations. And, for example, there were things I wasn't comfortable about and I needed to think about some more. There was just my own inertia that sort of often takes over, and I put things aside and it takes me a while to get back to them. But then, as often happens, I'll have a little bit of an aha moment. It's like, oh, yeah, no, the answer's here. And then I flurry of activity and you throw it out to co-authors again. And it's like, hey, guys, so where are we? I'm just looking here, number needed to treat. So just to put it in context, so we're familiar with the ocular hypertension treatment study. Yep. Or ocular hypertension, was it Oates? Yes. It was
Oates, yep.
Oates, yeah. Where they found that if you put a person on an ocular hypertensive for 5 years, you could reduce the incidence of glaucomatous field loss or optic nerve changes from, say, 10%
to 5%. Yep.
Okay. So
1 in 20.
1 in 20. Yep. So you need to treat
20
people for 5 years to prevent one case. So the
and
number
that obviously changes. I want to interject because I think some of our listeners may not fully think through this all the time, like you obviously do. But that number would change, obviously, if you're scaling your treatment based on risk factors. So patients that have thin corneas, higher IOPs, more suspicious nerves, family history, right? Like if their risk would go up.
You keep believing that, Chris.
No, you don't think so?
No, I'm being facetious. Yes,
Okay.
it probably does.
I'm not saying that to diminish what you're saying, but we've accepted.
I agree. That number, but that number needed to treat is 20 patients for 5 years
For the whole cohort. Yeah,
you need 100 patient years in order to prevent one case.
Right.
Okay, and that's to prevent one case of early
glaucoma, and we've accepted that. We've accepted that that's okay. Yeah,
it's become standard of care because we have in most cases cheap innocuous therapies, to do that. But when you get to my age, you come into contact with decisions to sort of treat. So my cholesterol is a little high. Okay.
Yeah.
Am I
1 in 300? 1 in 300 for a statin. You know that?
Yeah. No, it's actually probably in the paper. Okay. Because, I work with ophthalmologists who think about these things from, as physicians. But the numbers for statins are so
astronomical.
So let me just, where are we? This is probably not the best document to look at because everything's segregated. I'm just trying to find the table with the number needed to treat for myopia. So here we go. So so you can do the same math, and I'm sorry to keep you on.
No, it's good. I'll cut this all out. Make you look sharp. I'll make you look like you had it right off the top of your head.
Yeah, no. So the number needed to treat, to prevent 5 years of visual impairment, in somebody who's destined to be a -6 is about 5.
Whoa.
Okay? So the number needed to treat to prevent 1 year is actually a fifth of that. So It's almost a 1-to-1 ratio. So the benefits, at least according to our calculations, are incredibly favorable in terms of so 5 years of visual impairment. You typically need to treat 5 patients in order to get that benefit. Now the reviewers may savage that, but I've got some pretty smart people who've already looked at it, either as co-authors or as collaborators who now so take on the contact lens side. So if you consider let's consider a medium risk contact lens where the annual incidence of MK is 5 cases per 10,000 patients. So that's at the high end for daily wear. All right. You you go through the same math and you come up with the number needed to harm. The number of patients you need to expose for 5 years of contact lens wear to produce 5 years of vision loss. So it's the other side of that coin. The number's 190. So you're looking at 5 versus 190. The number needed to treat is 5. The number needed to harm is 190. So the needle is firmly pointing towards the the benefits outweighing. Have I lost you, Chris? I'll keep talking. The number needed to. You're back.
I'm back. Sorry. So you were. I got this. So you were saying the number of patients that needed to harm would be what?
190.
So you have to.
So basically, to save 5 years of vision
and harm is vision loss from
for vision loss from contact lenses. Okay.
Okay.
So you would need to expose 190 patients to 5 years of contact lens wear in order to produce 5 years of vision loss. And I'm saying vision loss because the criteria for vision loss in those contact lens studies is typically either 20/40 or two-line loss. Okay. And the other caveat is that's one eye. Okay. So like the old Sven and Oli joke, I'll risk one eye. If you don't know the joke, I'll tell you it offline. So however you look at this, even if you go to Ortho K and you assume a very high level of risk of microbial keratitis, it's still, the odds are still firmly in favor of, the scales are clearly tipped in favor of the benefits of myopia control far outweighing the risks. Okay. So, I may end up having my pants down on this one once this goes through review. But I really don't think so in terms of how you look at these data. And again, why haven't we figured this out before? Well, I had to first of all develop a construct to sort of compare, and I'll send you the paper so you can look at it and sort of go through and come back to me with more questions. I had to develop a construct so you could actually compare the risks of vision loss from contact lens wear with the risk of vision loss or vision gained from lowering the levels of myopia. But also, we've only recently got good data on the relationship between visual impairment and myopia level. And there's still really only a couple of studies out there. So and the data, I'm going to show you the data in a minute. Make sure where are we? Myopia visual impairment. I'm going to show you the data I use. Frequency redo. Here we go. All right. So I'm going to share my screen just to show you a graph here, or a couple of graphs.
Let me allow you to share it.
Yeah, I'm just making sure I got the graphs readily available because, like many of my spreadsheets, it's a train wreck in terms of, I draw a graph, then I draw another graph. Okay, so you see my screen now?
Yes, sir.
Okay, so this is, where are we? Let's go to this. So these are data from 15,000 patients across multiple studies in Rotterdam. And basically, I've replotted their data. The paper the paper this is from is called, so people can find this online, the Association of Axial Length with Risk of Uncorrectable Visual Impairment for Europeans with Myopia. Mm-hmm. But basically, they have in that paper graphs that show that, and you've probably seen these presented by me and other people, showing the cumulative risk of visual impairment as a function of age for different levels of axial length and different levels of myopia. Okay, mm-hmm. So this paper is publicly available, and it's, if you're willing to go through it, it's fairly accessible. You can be impressed by the data. But what I did was I said, okay, let's replot it in terms of level of myopia. And what you see here are a set of exponential curves for different age groups. But when, again, you put them on a log scale, those curves are straight lines and are remarkably parallel. That is to say, the relationship between cumulative risk of visual impairment and level of myopia is remarkably consistent across different age groups. Okay, so obviously the risk increases with age, the risk increases with level of myopia. So you can do a multiple regression and come up with an equation that will give you the risk of visual impairment as a function of age and myopia. Okay, so that's something we do in that paper, and we go about it.
Can I ask you one more question?
Sure.
There actually be a case where amount of myopia and myopic maculopathy are sort of they are not cause and effect, but they're sort of covariance together, where it's the case that even if so maybe patients are more at risk for developing more myopia, but also a separate risk at the same time that they're going to be developing myopic maculopathy, where even if we reduce that, they
so what I'm showing you here is
that's the other thing I think people might say.
Well, these data are agnostic in terms of the cause of visual impairment. So this isn't myopic macular degeneration. This is loss of vision. Okay. So obviously myopic maculopathy is a big component here, but so is detachment. Glaucoma is probably a huge feature here as well. But it's probably myopic maculopathy that's really driving this because, as we sort of talked about early on, each additional diopter of myopia increases your risk of myopic maculopathy by about 67%. Looking at these curves, each additional diopter of myopia increases your risk of visual impairment, regardless of age, by about 30%. Okay, so the other thing I wanted to show you is, this is one study. These are the same data here, but in the last year there was a paper by one of my collaborators published on French people, which essentially shows nearly identical data. So these are French individuals, the dotted line at the top here, over 60. These are French myopes under 60, and they agree pretty well with or very well, I think, with the Dutch data. So we've got some independent support for here, but it's only these recent data that look at visual impairment and eye disease as a function of level of myopia that really allow us to quantify what the potential benefit is regarding of the potential benefit of myopia control. So we can see here on these graphs and others the relationship between level of myopia and visual impairment or risk of myopic maculopathy or risk of glaucoma. They all follow a very similar trajectory. It's just the slope is slightly different. You can then infer, well, if I lower somebody's myopia or I save a diopter of myopia in childhood, there's going to be a long-term benefit that I can again quantify in terms of their risk of visual impairment when they get to be older. Now, one of the challenges of this field, twofold. One is from a public health point of view, you're intervening early to get a benefit later on, which may deter government organizations from paying for it because nobody wants to pay for something today that somebody else is going to benefit from down the road. So stay away from politics on that one. The other thing is that to do a study that would demonstrate
never going to happen.
It's not going to happen. Some people say, we've got the resources to do that.
No way.
Now, I'm just going to show you sort of some other data here that I'm preparing for a presentation next week, which is not public, but basically, you can begin to get some inference from some longitudinal data. So I'm going to pull up the soundbite here that sort of talks about this. And again, I want to show you the data, and also, show you what one of my smart colleagues has said in terms of doing this. I hate it when I get the Microsoft bar of death here. So what happens if I actually just get rid of that? Is it actually going to give me Microsoft PowerPoint? Anyway, let's see whether it comes to life. But basically, we are now seeing some longitudinal data where people over a 15 to 20 year period are looking at the prevalence of myopia and looking at the prevalence of myopic maculopathy and visual impairment. So there's a paper by, it's not coming up, so I'll just talk about it. There's a paper by Ueda, UEDA, that looked at the prevalence of myopia in the early part of the century and then more recently, and also looked at the prevalence of myopic maculopathy. And what they observed is that the prevalence of myopia at the turn of the century in their older population was in the 30s. Now, 15 years later, it's in the 40s. So there's been a 10% increase in the prevalence of myopia among older adults in this sort of captive population that they're studying. At the same time, the prevalence of myopic maculopathy has gone up from about 1.5% to 3.5%. So we have some longitudinal evidence showing a clear association between the prevalence of myopia and the prevalence of myopic maculopathy. Now, could we dig into their data a little bit further and see whether there's an association between level of myopia and risk of myopic maculopathy? They probably have the data to look at that. But again, these are things that are going to evolve in the coming years. We're going to have more data. We'll have a better sense of these things. So, I can clearly place my hand on my heart and say, in slowing down a kid's myopia, you're doing them a big favor down the road.
I believe that too. I'm just trying to, in that question I was asking was to try to play devil's advocate, because I do see times where people will say, we don't have a big randomized placebo-controlled trial that says that's going to correlate over time, and and when people say that, at some point you just got to say, well, okay.
But it's a reasonable inference.
Yes, agreed.
The thing I say is, like, if you're sitting in your consulting room and somebody comes in carrying an umbrella and their shoes are wet, it's raining. You don't need to go outside and check. Okay. Now that's a cross-sectional example, but I think the relationship between myopia and eye disease is so strong, and you see it across, a host of different studies. And we're now seeing data on the relationship between myopia, or level of myopia, and visual impairment. And, the first studies we're seeing, admittedly in Europeans, they look like they have the same trajectory. It's okay to take those data and at least develop a construct or develop a prediction of what good we might do. And as I said, you end up with, whether you look at numbers needed to treat, whether you look at years of visual impairment saved, then you can do a lot of good. So we're basically saying that in terms of an individual, we can save a year of visual impairment by slowing myopia by a diopter. Okay, so
this is great stuff, and this is exactly what I was after.